I think everybody knows that they're in the right place for the population study kickoff meeting. Thank you to Angie for joining us again today, and welcome to Scott. We have 90 minutes scheduled for this meeting, and we can definitely fill that. So we hope for a robust conversation. We'll of course start with introductions. We'll get to that slide in a moment. Move into a project overview, our background and purpose. We'll get into the phase purpose, specifically about population. We'll ask some critical questions, and we'll move into discussion. We'll look at a checklist overview for the data request that will be foundational to the rest of our phase and really contribute to the other phases as well. We'll look at a detailed phase schedule, and then we'll kind of chart the path forward before we adjourn. So for introductions, I'd like to invite the IHS folks to introduce themselves and popcorn to others. Jonathan, did you want to start today as well?
Sure. Good afternoon, good morning / afternoon, everybody. Jonathan Rash, the Director of Environmental Health and Engineering for California Area Indian Health Service, and I'll pass it to Ali.
Yes, good afternoon. Ali, Program Manager with the Facility Engineering Program in Sacramento, California, with the Indian Health Service. I'll pass it on to Christine.
Hi, good morning. I'm Christine Brennan. I'm the Associate Director of our Office of Public Health here at the California Area Office. And I believe that is all the California Area Office staff on.
Hey, Scott, do you want to take it next?
Sure. My name is Scott Black. I'm Chief Executive Officer of American Indian Health and Services in Santa Barbara and now also in Los Angeles.
Would you mind telling us a little bit about how you came to be part of this work group and planning effort?
A lot of pressure from Jonathan. No, just kidding. No, I serve on the California Area Tribal Advisory Committee as the Urban Indian representation. And so I enjoy working with California Area Office, worked in other area offices in the past. And we're blessed to have the team at California Area Office. So this is a big focus of our program, and our new chief medical officer. So unfortunately, it's just really, I know no one has a lot of time on their hand, but this week's just crazy for all of us. But I work with on a lot of projects with the team at Area Office, and I just want to be supportive. And of course, it's going to have such an impact on all of our programs that I just think it's really important information.
Thank you. I don't think Angie is back yet.
Yeah, if you're waiting for Angie, we just hired a chief medical officer in July, and she came from Honolulu at Queens Medical Center, and she was their population health. I guess she said she didn't want to be called officer, but administrator for a team of about 130 providers. So absolutely her focus, and she's in good company here at our organization.
Well, we can move forward. So my name is Alex Hokkanan. I'm the Manager of Design Research and Sustainability here at Bodwe. I'm the project manager for this project. Stephanie, do you want to introduce yourself?
Hi there, I'm Stephanie Sokolowski. I'm a studio director at Bodwe Professional Services Group. On this project, I'm the program manager overseeing all of the task orders on this IHS planning IDIQ.
Kate?
Hi, I'm Kate Ashford. I am the project assistant assigned to this project, helping out with some of the technical writing.
A little bit of background on us. Bodwe is a professional services group, and we are wholly owned by the Pokagon Band of Potawatomi. We're kind of centered here in Southwest Michigan, but we've got offices and do work across the country, whether that's architecture, planning, or engineering services. In Potawatomi, Bodwe means to light a fire for someone. So that's really our kind of centering calling that fuels everything we do.
Great, and we're partnering with WBK or Bodwe on this project. The Innova Group is a consulting firm that has a long history of working with tribal entities in the IHS to develop strategic plan, facility plans, and most importantly, this regional specialty care center for the California area. We have quite a few various professionals from different sectors, from administrators to nursing staff to architects that will help shape and form this study. And on the right-hand side of this slide, you'll see the team. There's quite a few of us. Myself, I'm Carmen Zamora. I come from a health center operations background. I've been with the Innova Group for 9 years now, working specifically with tribal and IHS entities to plan healthcare systems. I'm going to turn it over to Anthony to introduce himself, and then the rest of our team to introduce themselves and their role on this project.
Thank you, Carmen. Good morning, everyone, or afternoon. My name is Anthony Laird. I'm a planner with the Innova Group. Been with the firm for about 25 years, and my connection with this project is I've had some relationship with California that ties to this since 2004, probably, when our firm was involved in the Area Health Services Master Plan, which involved connectivity, site visit, information planning work for each point of care in California. That was present at that time, and out of that grew this idea of perhaps the regional synergies. And so it's pretty cool to see it come to this point, and had the privilege of working on the last 2 regional study reports as well. Thank you. Let's see, Scott.
Good morning. My name is Scott Spann. I've got over 25 years of operational experience and spent the last 3 to 4 years with the Innova Group. I've got all backgrounds of administrative and healthcare organizations, up through leadership entities, and really towards the end of those years, more leadership roles, both in the public and private sector. And I've done a considerable amount of studies on the governance side of things with the VA, and look forward to the opportunity to really learning from all of you and developing the way forward for kind of a governance perspective of the new regional health centers. Thanks.
David?
Hello, everyone. I'm David Ayers, Senior Healthcare Planner here at the Innova Group. I've been a planner here for about 9 years, going on my 10th year. I've been in healthcare for about 20 years, most of my career. Held a variety of roles. A lot of my background stems from data analytics and just overall data roles in general. Data management, data warehouse building, things of that nature, models, and so on and so forth. For this specific project, I'm going to serve as the population study lead. I'm actually very excited about this project and looking forward to it. I think this is a very unique project and a unique opportunity, obviously for the California area, but also as as we go forward and think about how to improve care and do studies for other areas as well. I think there could be a lot of lessons learned that comes out of this project. So I'm very excited to be a part of that. So thank you.
And Daniel.
Good afternoon, all. My name is Dan Hay. Been with the Innova Group for just under a year. Over a dozen years experience in healthcare financial planning and analysis, as well as strategy for partnership and transaction advisory. I am the PERCTA study co-lead with my colleague Kent. I'm very interested in this particular phase as well as the governance, but this one as well, given the importance that the population study and defining eligible population will have on the PERCTA and just the broader California, American Indian, and Alaska Native population. Thank you very much.
And Haley.
Hi, I'm Haley. I've been with the
We can barely hear you, Haley.
She was having microphone issues yesterday,
Okay.
so we might want to jump over to Sailor. Well,
Sailor, are you there? Sailor's on the call. No, I don't think Sailor's on the call.
Oh,
Okay, so that's the Innova Group, unless Haley's been able to perform microphone magic here.
and she'll be serving in a capacity in data analysis capacity. She has a lot of public health background experience, and is a great add to our team. So sorry, just thought I would put a plug in for her.
Thank you. So we're not going to spend a lot of time on the project overview, but we do want to give you just a quick sense of perspective. As I've already alluded to on my introduction, regional services planning began many years ago, not formalized, but in the 2005 Health Services Master Planning effort, we began to dialogue with the health organizations that we talked to about potential synergies with other THOs or perhaps area-wide. And we framed up some potential regions to explore what the healthcare demand might be for those and what kind of services they might support. This was formalized in 2013 in the first study entitled Regional Ambulatory Surgical and Specialty Health Services Feasibility Study. That's a mouthful. But it began to define the services of what regional care might look like, and it also began to identify the best scenario for locations. We explored everywhere from 6 potential sites to 2 potential sites. The 2 sites was essentially decided on, and thinking began to develop. 2024, the 2013 study was updated. Population was studied again and updated, and services were reevaluated relative to what that increase in population might support. Staffing and size of the facilities were updated relative to population and services growth. And so here we are today, continuing to lay a foundation for that through these additional studies, one of which is population. So the population study, as I alluded to earlier in our opening casual conversation, population is really super important to me. The long and the short of it is, at the end of this study, we're looking for a number. At the end of this phase, we're looking for a number on which to size and plan 2 points of regional care. Now, that number, depending on how big it is, may tweak some of the services that the regional centers may support. But the services for the centers have already been a point of great conversation, and those have largely been defined. But we will revisit them when we come back around after this study and that population number is defined. We have a mechanism in place on how to think about how distance might affect people traveling for care, how alternative care might affect people traveling for distant care, how quality of care might affect people traveling for distant care. So we have those methods in place. We're looking for what's the number. In California, that's a particularly challenging conversation, because we know there's reporting issues. We know there's issues related to urban populations and perhaps some populations that we're missing. So the other two studies will be associated with this, the governance study and the PERCTA study, but this is what we're here to talk about today. So I'm going to turn it over to David to talk about the purpose a little bit more of this particular phase. David?
Thank you, Anthony. Yeah, so as Anthony alluded to, really the goal of this phase is to arrive at what we think is an appropriate and a sustainable population number that will form the basis for the planning that will go into to these regional care centers, and ultimately the planning documents that'll be required as outputs, which is the PJD and the POR. Now, in order to execute this and do this well, we're going to have to work closely with the California area office, the service units, the urban programs, and ultimately IHS headquarters as well throughout the process, because we do recognize there's reporting challenges that have to be worked through, as well as any gaps in the data. And so the way we're going to do this is we're going to ask the question, what other sources of user populations should we be considering? As part of the data request that we'll get into later, that we're going to be submitting and asking for feedback on, will include a list, our initial list of those sources, and we'll just want to get feedback from the broader group about what else should we be thinking about, what other data sets might there be out there, to help us get at what that right number ultimately wants to be. And so one of the other questions that we'll be asking, which is critical in terms of the overall size and impact to the overall program, is going to be who should be counted as an urban native, right? What is that urban native population, and how should we count them relative to regional care? And as Anthony already basically indicated, we have an idea, we have a methodology for how we do this, but we have to make sure that it's in line with what IHS headquarters would support, while striking that balance of respecting the healthcare needs that the California Native population needs. And thank you. So at this time, this is, as you already know, because we did this Monday, we kind of want to get into asking the questions, right? So thinking about this phase, which is all about population, we want to ask these questions in that context, So those are the three questions on the left. What is most important for you in this phase process and outcome? What does success look like for you at the end of this study? And what, if any, concerns do you have at the outset of this effort relative to past planning efforts moving into this? And I think we're going to do this. We're going to do this live. Is that right, Alex?
It is.
Okay. And just a point of reference, a little lesson learned from Monday, if you need, we recognize that it can be difficult on some screens to see. So if you need to zoom in to see what's being typed, just use the little plus in the lower left of your screen.
And feel free to let us know if we can zoom in a little bit more too.
So since we have two of the work group members here, the good news is you two have a lot of time to share with us your thoughts and concerns. Yep. And if you know from colleagues and peers, you can share concerns you're aware of that others have. We would love to hear it. This is really the heart, in my mind, the heart of the presentation. We want to hear from you entering into this population study effort. What's important in the process to you? What's important in the outcome? What does success look like at the end of it? So anything you can share with us, we'd love to hear. The floor is yours.
Okay, this is Angie. I'm going to go. So I would just say this. So I think and I appreciate the context of what this meeting is centered around, which is really the population data. I think that in my personal opinion, how I see it is I'm concerned that we're not going to that we need a methodology to have responses from tribes on what their actual data looks like. I think we need to consider, what are the mechanisms for gathering that data in urban areas that currently don't have tribal participation, or maybe in some cases where urban Indians don't even access the urban Indian programs, but may access a tribal program once they take on PRC. And I don't know what that looks like or how that's going to be gathered, but I think that's important. I think the biggest concern that I really have in realistically getting these regional centers out and off the ground is I naturally look to, we all know, and I worked with the Innova Group when you guys did the master planning process with the Phoenix area. So obviously, the importance of planning for these facilities and the size of these facilities and what services are going into these facilities are really oftentimes impacted by user population and growth mechanisms in there to account for just general growth. But if you don't have good consistent data, and that was one of my issues that I had here in our clinic because of challenges with our reporting into the national data warehouse, or challenges with even the EHR system that we were using at that time, where we weren't capturing what we needed to. The challenge that we had was we ended up with a study that we're already exceeding in some areas because of it. And so that's what I worry about with this process, is having a concentrated effort where we can really get tribes to submit true data. The other thing I would just say, and I'm just going to keep talking, you can do whatever boxes, because just what comes to my mind is, I think that under this current administration, we're seeing some things that in the field that maybe we haven't seen before. And sitting on the FAB, I was concerned because I was looking at the Doge site, and that's when I saw, some of the area offices, including our California area office, was listed on that site as a lease that was going to be gone. And of course that turned around, but what it did was it sparked concern based on the reorganization that's also coming, where I feel like there's a lot of reorganization from the federal agency side, but also I know that they are looking at that at the Indian Health Services side, where Indian Health Services has input but may not have all the input that's really needed or necessary. And when I think about that, I just need to make this point, so you'll see where I'm going, is when they reduced the regional CMS regional offices from 10 to 4, that was alarming, because what I hear across the board a lot is, 70% of tribes have taken a Title I or a Title V and taken over their services, meaning that there's very limited direct service remaining in the Indian Health Services across the nation, and probably even more so true in particular areas such as California. And I know that we had this conversation on yesterday's meeting, but my concern is that I think we have to be forward thinking about how to support these regional specialty care centers that, and I'm saying this as a California tribal member, that we have got to be able to think outside of the box of what we always thought in, which is just that box of California. And this is where I think that we have to be smart enough to include other areas that would utilize this as well, including Northern Nevada and maybe even Southern Oregon. And I just say that because the likelihood of getting support around this may be contingent on some of those factors in this current federal environment. I know that's not going to be a popular thing when it comes to our tribes, our California tribes, but I think it's the reality of where we are in today's environment and the next 3 years of what that looks like ahead of us. That we know is the situation that we're currently in. So for me, I think we have to be open to what that's going to look like to support what we need here in our state.
Angie,
So,
did I hear you right? You said you're a member of the FAB?
Yeah.
Okay.
I'm the alternate for
okay. So just for our team who may not know, FAB is a pretty important group, Facility Appropriation Advisory Committee. And so it's a group that has a fair bit of influence. So thank you, Angie. I just want to come back and define that acronym. So thank you. Didn't mean to interrupt your flow.
No, but I think those are just concerns when I think about the specialty. Because in all honesty, I'm worried about our region. I'm worried about our area offices in the ongoing discussions that are happening. So it makes me think that if we have to be also creative as well. I think that's what I can just assure you, that is what the secretary is looking at. And I think that's concerning.
Yeah. Are there, well, I should shut up. Other thoughts, other concerns?
Hi, this is Scott. One of my concerns, or maybe it's even what I'd like to see come out of this process is find a way to have more accurate data. I heard you mention PERCTA, which is something urban support because it benefits the tribes, but it gives it so dramatically skews the number of Native Americans we see in at an urban program if we have a tribe near us. We expanded, I'll give you an example, we expanded into Ventura from Santa Barbara, I think in 2010, because we had so many Native Americans using our facility from another county that when we would report then on GIPRA only, they wouldn't even show up on the report. So then we expanded our service area to include parts of Ventura County, and it greatly improved our numbers since we were already seeing the individuals then. And now with PERCTA, for the most part, I can't say it's 100%, but it's close to 100%. If a Native American patient comes to our facility and they receive services here from Ventura or even a lot of places, it doesn't even show up on our report that we saw the patient, and they might have had specialty care. They probably came here for oral health, which is kind of our specialty, but yeah, it's I don't know. I know they count somewhere, but I don't think it's accurate. And then of course, patients they go to where the service is available. So if someone has they might be in an area that has a long distance to go to a tribal program, they might go to multiple tribal programs. I don't know how that data is reported, but they might receive excellent counseling somewhere, and then they might like their primary care provider at another one. So we know our numbers. I can do a physical audit of all the patients that come here, and then when I see the report on how many Native American patients we see, it's just maddening because it's not reflective of what we see. I talked to Sonia one time, Tetnowski in Santa Clara or San Jose, and she was getting reports that she saw one Native American, and yet she's got probably 100 programs where Native Americans tend. So that's a little frustrating. We understand that, and Jonathan and I have had a lot of conversations here. It just makes me wonder how accurate the data is being reported when they do go to a tribal program, or if they just go to other services, elsewhere. We are not unique, but we have a tribal program. Saying as tribal health is 26 miles away. So there's a tribe and an urban program in basically overlapping service areas. So, and we partner really well. We see, they send a lot of patients here for specialty care, but yeah, I wonder about, yeah, that's such a huge concern that we're actually collecting it. When I see the information on how many Native Americans use the services in California, it's a big number, but it should be much bigger. And I believe it is much bigger. The other thing, and I don't know if this is a concern or what, but since there's not something available to so many of our Native Americans in remote areas, that they find ways to be seen, and maybe it's at a non-Indian federally qualified health center, and they may or may not collect that data, or they have a, you know, you don't have services available, so you only use hospitalization. I mean, I got to go to urgent care, I got to go to hospitalization because it's just, I mean, I hear reports of it being 200, 300 miles away just to go to care. And that's always really concerned me about California. I used to live in Alaska, and I lived in a remote village, and we didn't have any care, but somehow we were able to get it. We could go to Anchorage, and one of my daughter was born at the Indian Hospital in Anchorage, and we didn't even have health care out in the middle of nowhere, but those numbers were recaptured. So yeah, I think I know, and I believe most of our partners, with all the number of clinics and how busy they are and all the services they offer, I believe we're not capturing the need here, or the volume of use, or even, like I said, I hate to keep repeating myself, but the things we don't know what we don't know. We don't know where these Native Americans are receiving their care, but I believe it's wherever they can. I mean, not only are our programs resourceful, but our people are pretty resourceful too at finding something. So I don't have a solution on how to capture that. So, but I think it's a real problem.
Scott, you're at Santa Barbara, is that right?
Yes.
So is it, and Jonathan, you may know this too. I mean, we look at that data, and sometimes a user or native comes see a clinic. When the data is actually recorded, it can go by community of residents. And so is it possible that some of your patients are being counted in Santa Ynez, like they're being counted there?
Yeah, well, we know that's the case, but there's not a program in Ventura, and yet I probably have 160 Native American patients who will drive from Ventura, maybe more, because we have a dental clinic that's 2 miles from the Ventura border now. But we collect their zip code and stuff, and we enter the information in, and then it's not on our reports. And we even have a lot of patients come here from all over Los Angeles and Simi Valley and everything. And
yeah,
I didn't mean to complicate it with the comment about Los Angeles. I mean, Los Angeles identifies as having 150,000 American Indian or Alaska Native in their county, and yet we're just we're in the first early months of revamping medical, dental, and behavioral health in Los Angeles. So I know the numbers are there, and they got to be receiving care somewhere, but
yeah,
specialty care is just not available to these individuals. So
yeah.
And I've been on a few of these, the Innova presentations. I think there was one that I didn't see in there, unless, I mean, time gets away from me, and maybe it was the 2013, but I remember when Margot Kerrigan was still the director before Beverly was, and I think there was one there, and we were having similar conversations. But we know there's tremendous number of Native American in California, and I don't think that the need gets identified accurately. I mean, it's not a criticism. I just don't know how to do it. It's just not happening. But.
Oh, for sure. Carmen, I think I may have cut you out. I apologize.
Oh, no, you didn't. I was just going to add to that question, Anthony. when you spoke about the tribe, I think it was Sonia's entity.
Oh, the urban program up in
Yep.
San Jose, Santa Clara. Yeah.
So where are you reporting when you look at your annual visits and individuals that are coming to your centers? Do you report that into NDW or using RPMS? What system?
We don't use RPMS.
You do?
We do not use RPMS,
Don't.
but we do report. But it doesn't seem to reflect our numbers. But
Yeah.
Interesting.
Yeah, we know that's a problem. One of many, but we know that's a problem.
You know, part of the reason we're excited about Los Angeles, and it's big, and it, probably 100-year project, but in Santa Barbara, San Ynez and Santa Barbara are pretty well known in our local area. In our service area, and we draw the line at San Ynez, we don't want to encroach on them, but we identify that it's a small number, but it's 2,400 American Indian or Alaska Native live right in our small service area, which is Santa Barbara and close around there. 1/3 of those individuals use our service. So I know it's not big numbers, but it's a big percentage. And if it shows if you had services local enough to Native Americans, the volume of patients that would be increased. That's my opinion. I think that, Los Angeles is like 150 Santa Barbaras, so you'd never be able to have the same coverage that we do. But if we did, look at the numbers we would have. There'd be, 500,000 Native Americans receiving care.
Oh, it'd be huge. Yeah. So you said you had 2,400 in your service area. Is that right?
Correct.
And so if you say 1/3 of them, so I'm just curious, you may not know off the top of your head, we'd expect that, 800 people, if I'm doing my math right.
Yep.
About 3,200 primary care visits. Does that ring true with you?
That's very true. Yeah, it's a little higher percentage. Our Native patients use the
Okay.
services at a higher rate than others, but it's because that's our focus,
Okay. And you serve non-natives at your clinic as well?
Yeah, we do. We're HRSA funded as well. So,
Okay.
but it's a survival mechanism.
Sure.
Yeah.
Understood. Yeah. Okay. No, thank you. Great.
Sure.
Other concerns? Angie, anything you want to add to what Scott said or?
No, I completely concur, was, the concerns. And I think, like I said the other day in our meeting, it's not just the data, for even like the PRC project that, is being worked on, but, for health advocacy, it also impacts us there. Like you just heard Scott say, we're HRSA, we're a HRSA program as well, because we don't have a choice. It's a funding mechanism issue to keep our doors open. And that is the challenge for California tribes. And I would say the lack of accurate data impacts us even on the Department of Healthcare Services side for advocacy to expand billable encounters and what that looks like to the state's federal medical assistant percentage calculation. So it's been harder for our California tribes to sustain healthcare it is so completely, it's not even anywhere near an equitable thing from all the other tribes and states all around them. So this data issue is not just a IHS, PRC, this rollout, it even, goes over into, it's impacting our inability to effectively at least have any type of equity in reimbursements for sustainability for the ITUs.
Just so each of you know, we wrestled with this in the last update of this study, and I don't know if you read that or not. It's not exactly something you read before you go to bed at night, for sure. But but we did wrestle with it, and I don't remember the number exactly, but I think maybe for, I don't know, Jonathan, correct me, or Ali, correct me if I'm wrong, but I'm thinking for, maybe 60 to 70% of the points of care, we took the IHS understanding of what the user population was, but for the others, we just said, no, there's reporting challenges here. It's not believable. The site doesn't believe it. And so we searched for another way, another population number to use, whether it was just what they told us or what another report we were able, another accepted IHS report told us. We looked, and I think for this, it's really super critical, in my mind, to be thinking about where do we need to look? What are the places we need to look to get to the right number and bring people along so that at the end of it, we're all nodding our heads and going, yeah, that's the best number. Maybe it's not perfect, but we've looked in all the right places. We've talked to the right people, and it's certainly a different number than IHS would understand. But our number was much bigger than what IHS would understand, and it probably could still be bigger, But so what we tried to do was we tried to put a stake in the sand to say, hey, in this update, IHS just recognize we don't buy the HSP, health systems planning, the IHS. We don't buy the IHS number. There's problems here, and we need to look more deeply, and hence this study, I think. And Jonathan might comment on that, but hence this study. And so here we are. So I know when David talks about data in just a minute, we're going to be asking you both what questions, but we're going to be asking you where questions. Where do you think we need to be looking to get numbers that everybody will buy into? And so anyways, I just appreciate your thoughts. I know it's a big thing. So
I think a lot of our programs, they know their numbers, and sometimes it just takes physically looking at them because, like I said, I didn't go from seeing 168 patients in Ventura to 0 all of a sudden, because the same patients can tell me everything they know about their primary care provider and love them and the services. So I know it still happens. So we probably individually are probably the best data. And I'm not saying just take my word for it. We scrutinize. We know we're spending our dollars for Indian health on Native Americans. I mean, that is our mission. The other thing is, I know it's hard to do, but there's a lot of you. So ask for invites out to some of the programs. I mean, we would welcome you, and you get a lot more than just the program. We had a meeting yesterday with Cottage Hospital, and I apologize, I went on another call, but we had this one. We were trying to get them in the room for forever, especially with everything that was going on. And seeing our Native American patients that show up there, we have you pick two good people, me and Angie. We'll just keep talking until you stop us. So we have a board member who is the behavioral health officer for community health centers of the Central Coast. So 1,000 employee FQHC in northern Santa Barbara County, and they're in all the little areas. So they serve a lot of Native Americans, and a lot of Native Americans go to see. Her name's Magdalena Serrano. They go to see her or her team because they know that they can at least have a conversation with a Native American provider or a Native American director, even though it's not an Indian clinic. I would venture to say their numbers are greater than ours, but they're a true HRSA FQHC, and they may or may not collect all of that information. They ask it, but if someone says, well, I don't want to tell you, or I just want to receive healthcare, that might not be captured. So I don't know what the solution is, other than those conversations are, they're pretty accurate with our other healthcare partners. It's not just what are we seeing at a tribal or urban facility, but even, our surrounding area. One of the other things is listen, if you could get to the programs or even just have a virtual call, you got to hear the stories from the providers and the staff, in the community, because we just enhanced our program on women's health for mobile mammography. We bought a bus with ARPA funding, and we're starting to partner, and we're going to make it available to tribes because it's such a cool project, and we've got a good relationship with Harbor Radiology to read our images. And we focused on this because, since we're talking about specialty or what would hospitalization or even service that we can't offer here, we did a big push to identify how current our Native women are with their breast exam, and the average individual was 12 years out of having their most recent mammography, and that didn't even include the ones that, Medi-Cal or some guideline might say, oh, you're too young to get a breast exam, even if you have a history, So we want to get rid of all of those barriers, and we feel like our tribal partners are the best way to do this, is to make this available. But yeah, can you imagine the rest of the population if someone told you, oh yeah, the average breast exam is 12 years out of compliance, and that was our average. We had a couple that were at 22 years. I mean, that's a mature generation, honestly.
Yeah.
They have probably daughters that could be considering it at that age. So I just say that because it's our firsthand, and it's a story we can tell. And many of these patients were not our patients. They just recognized that American Indian whatever health and services or American Indian Clinic was having this focus, and the word gets out, but so I don't know how to measure that, except it's real.
One thing I wanted to throw in real quick was just as a reference, you're talking about FQHCs. Carmen, she didn't raise it, but Carmen has pretty extensive background with FQHCs, so her smell of the potential connectivity and what could be learned, I think will be helpful moving forward.
I was already on the HRSO data warehouse website looking at market leakage and how many Native Americans are being served in LA County. But that's an interesting way to overlay the data with what we have currently. So I appreciate you saying that.
Angie, were you going to say something? I'm sorry.
The only other thing I wanted to add is, I think it's difficult to figure out how are we going to get here with the numbers. I think there was a California area consultation that happened, I want to say back in last February. I don't remember. It feels like it's one meeting after another over here on my end. But one of the things that was said by a colleague of ours is, they were looking at the areas, all 12 of the areas and the populations of those areas, and that California area came in as the 8th out of 12 in its population. And, I think that there was frustration in the room from some tribal leaders, feeling like, our numbers are a lot higher than that. But I think that there was reference to census numbers, which are very different from user population numbers. And so I think that that's a challenge, because it feels like it's also kind of educating, tribal leaders on kind of how these systems work, like what we were talking about earlier, what Scott was saying is, there's user populations and communities that are assigned, and then how you're gathering that data and how that contributes to whatever. So I think those are that was a comment that I had heard from somebody that was talking about, well, we're 8th on this list, but technically, when you look at the census population, we should be the number 1 here.
Yeah.
So I think that there's a stark difference between what that looks like.
Yeah. Jonathan, you had your hand up.
Yeah, I wanted to elaborate a little bit more on that, and Christine can as well. Christine posted this data comparing our numbers, census versus sort of the IHS user population. Oklahoma and Alaska, their numbers lined up very close between their census count and their IHS active user population. Our IHS user population is like less than 10%, maybe on the range of like 5% of the Native American census population. Dramatic difference. And of course, a lot of that is in urban areas. There's a long history here that maybe all of you don't know in terms of, you know, the termination of tribes and the forced relocation or the encouraged relocation of Native Americans from their homelands into urban centers. And to me, I think that's the real crux of how do we get data that counts those people so that we can size our regional specialty centers accordingly. And the little hint that I got from Buck Ellingson, who used to work for CRIB, now he doesn't anymore, but he gave me just a hint that maybe possibly Medi-Cal might be a good source of data. My understanding is, you know, Medi-Cal now especially has to differentiate who is or is not a tribal member, because that actually, you know, the new, you know, more strict Medicaid interpretations that the federal government has brought down is supposed to exempt Native Americans, but you have to then know who is or is not Native American. So I feel like if we can get the data that we need and conferring with IHS headquarters what data they will, you know, accept, what, you know, what format they need it in or whatever, that could be the holy grail for all this, maybe.
I think, so just let me speak to this for just a second. What we found, and I think would bear out, you know, if you're in South Dakota, rural South Dakota, and you need to see a doctor and you're Native American, you've got one choice, really. You go to the IHS clinic, you go to Pine Ridge, or you go to Ogallala, whatever it is. But if you're in LA, there's a lot of options, and very few, if any of them, are IHS or tribal. And so what happens, it creates this sharp relief between census and users. In a rural, land-based, mature IHS/tribal delivery system, we found the user count is more likely to equal or even exceed the census count. Because you have tribal members who say, I'm not going to tell the government that I'm Native American, but I'll show up at a Native American clinic because I am Native American and get care. And so, so the other side is equally true. You have in an immature, and by that I just mean there's not appropriate health care and huge population and few IHS or tribal options, you have this sharp relief between what the census count is and what the user count is. So that doesn't surprise me at all. And I think there's a fairly easy case to be made for that. I think the question in association with that is, how does alternative care bear in on what that number might be when it matures, you know, assuming there is a regional point of care? What is, and I hate to use the S word, but how do we speculate on what that might be? You know, what kind of argument can we craft for that makes sense? So, and I think IHS headquarters will understand this. It's just, what's the supporting data we marshal for this? So thanks for bringing that up. It's really a really relevant part of the conversation. And Jonathan, thanks for speaking to that as well.
You know,
This is Christine.
Oh, go ahead.
I'm sorry, I was just going to mention another source of possible data is Covered California. You know, the Affordable Care Act. We do have a lot of our tribal health programs who have staff that can help their tribal members enroll in the Covered California plans.
Yeah, and that's a good point. Some of us work with Covered California on the advisory committee, but it's still a very small number. But you're right, they do have a number. I can't draw it off the top of my head, but I think it's right around 8,000 people are covered in California that identify as American or qualify. They don't just identify; they qualify as American Indian or Alaska Native. But I know Buck very well. Worked with him at Sakui and Crib. But yeah, I don't believe for a minute Medi-Cal is going to touch who's an Indian, who isn't. No matter what the regulations are, I don't see that happening. But it's just my opinion. If they were going to make that decision, they would, through FMAP, they'd be collecting $100 million instead of $3 to $5 million based on being reimbursed for the all-inclusive rate. But maybe I had too many years in private sector. I always follow the money.
Well, and just to also follow up on that comment is, I just met with the representatives from the state on this very issue, on the numbers, and what they informed us is they don't keep track of them, but they're relying on the tribes numbers that the tribes report to the state, which is an even bigger issue here. Yeah,
so, a much bigger issue.
Yeah.
I see your comment, Jonathan. Yeah. No problem.
Yeah, we probably want to respect your time. The comment's great. I'm wondering if maybe transition a little bit to the kinds of things we're going to be asking on the data request, if you're okay with that, because we want your feedback and input on that, and we're going to be sending it to you. So where'd my presentation? There it is.
I'm working on it, Anthony. I'm working on it.
I hear that. There you go. So David, why don't you maybe talk us through this a little bit?
Yeah, so as the conversation has gone, we have a number of questions, and some of them are geared towards the area office, some are geared towards the service units, and then of course we have some that are geared more towards headquarters. It's a variety. There's a sampling of them on the screen, but I think there's also a sampling of them in your handout as well. So, just understanding all of the different points of care, the communities, the corresponding counties served, user population by, ideally we want to get it, I think, for the county level, but if we can get it by community as well, I think that's advantageous. We're going to ask for it in a variety of different ways, many of which we just talked about. We touched on Medi-Cal. I think Covered California is a good one that I don't think we have anticipated that we'll want to add. But ultimately, we're going to be providing this to you. We're going to ask for your feedback. Does it sound like does it look like we've captured every source that we can think of? What should we add? What should we remove? What's not worth chasing? Things of that nature. And then we'll ultimately, review that with area and then ultimately get it distributed so that it can be fulfilled. Obviously, this is it's a lot of data. It's a lot of different sources. It's going to take some time to work through. We'll get to it at a later slide, but I think we have some dates just targeted just to try to help keep the schedule moving. But I think we'll recognize that it's a time-consuming effort, and we may need more time. Alex.
It certainly
Can I interrupt to make a comment?
Yes,
based
sir.
on that last?
Please.
Sure. So I think there's one thing when I talk to our tribal partners, there's a lot of tribes that insure their members, and I think there's a notion that they might be not penalized, but it might be a problem for them to report that numbers. Plus it's really not anyone's business if they insure their tribal members, but they do it so that they can receive care wherever that is, no matter what, they want to make sure they receive care. And if nothing's available, then I believe that happens. So since you brought up the S word, speculation, I think we can speculate that they, again, they are receiving care somewhere, especially if they're insured.
That's a good point. It's
Yeah.
a really good point. I totally understand why tribes do that. It makes perfect sense.
Yeah.
Alex, you were going to talk to this. Sorry.
Very, very briefly, because it is reprinted and available to inspect at your leisure in the handout. But just overall, we're here at the beginning of October now, and we're looking through basically the end of September next to complete this. And as others have noted, this will take some time to ensure, especially for this study, that we get to a mutually agreeable number that we can all support. So I would refer to your handout for a deeper dive into the schedule.
And can I just piggyback on that, Alex, because I love to talk. Sorry. I was just going to say that the schedule will move as fast as we can. I think one of the things, if you think back to earlier in the presentation, we talked about working with IHS headquarters. We have to bring headquarters along as a partner in this, one of many. And so it just seems smart and wise to get their buy-off along the way. So this is what we're looking at. And we'll give them some versions to look at to give feedback on. So when we get to the end of it, hopefully they say, yeah, that makes sense. You've made your case. So how long those reviews take when we send them something, your guess is as good as mine. But that may affect the schedule by some weeks. Okay. Thank you, Alex.
So some next steps. So again, just to reiterate, we have a more complete data request checklist that we will send out and ultimately ask that the work group review and provide some initial feedback that we can work towards a final version of. I think one key piece that we need to touch on still is who at area wants to be that point of contact. Who is the best person to be that contact and help facilitate the data request? We're identifying October 10th as a time frame for us to get the final version out or get some requests back, I should say, from the work group initially before we finalize it and send it out and review it with area ultimately. So again, early November fulfillment target date for getting the data request actually fulfilled. It's probably optimistic, but got to put a stake in the sand somewhere. So we're just kind of targeting that. We may get some data. Some of the data sources may be easier to get by that time than others. So just recognizing that we may need more time.
I'll be the point of contact. If you could maybe put together what you want that some draft language for that, additions, deletions sort of thing, I'll be happy to forward it out to the group.
Okay. Sounds good, Jonathan. Thank you.
Thank you. That's great.
And same, by the way, for the Monday one as well, the governance.
Thank you, Jonathan.
And also, kind of in addition to that, or maybe it could be even the same email, if you can send me a link to the recordings, I'd really like to send those out as well to the people who weren't able to participate in person. Or
right.
Live, I guess, not in person.
And again, I would just add to what David said. When you and your fellow work group members receive the data request checklist, again, we're not asking you to complete it. We're not asking you to fulfill it. We're just asking for your feedback on, yeah, I think that's a good piece of data to go after. No, I think that's a fool's errand, or you know, you haven't thought of this, you should be looking here as well or considering this information. That's the kind of feedback we're looking at. Or maybe you say, that would be great data, but I think getting that from people is going to be impossible or take you 3 years and 100 site visits to get it all together. So just wanted to add that.
Can I make a comment about service areas? So I know there's never a fair comparison, but you go to budget formulation and there's a comparison. You know, it's not even a hidden agenda. So yes, Oklahoma and Alaska have huge user population at their Indian facilities, but Oklahoma, I mean, when you have Oklahoma City and Tulsa, most of the users are in that close proximity, in my opinion. I know the urban program and some of the other service units, I know of them and providers that work there. And then Alaska is, of course, spread out everywhere, but there's no other option. So, I mean, I know that firsthand from, you got to get healthcare, you got to go to it. Which brings me to another topic, transportation. But for California, if I remember your reports correctly, yes, we have large cities in California and people receive care there somewhere, usually not for the most part at an Indian facility because it's just outpatient care. Right. If that, but when you leave the big cities, you can still be 300 miles away from a hospital, I think, or at least 200 miles away from a hospital or specialty care and still live in California, and even live on your tribal land or in your community. So, I mean, there's always going to be a comparison, but there really is no comparison. Each area is different, and and it all brings us back to what's available. And then as far as transportation, I've seen some funding recently about transportation, and sometimes that even needs to go beyond just the tribal or urban program. We need to have those partners who could focus on that and get individuals to travel to care. Because I mean, even if someone says, "Hey, I can get you in tomorrow," you're a day away.
Yeah. We did in the update, we did explore the feasibility of, and help me with this, Jonathan, transportation, durable medical equipment, a regional pharmacy hub with specialty support, lodging.
Yep.
And
telemedicine.
Yeah. So, and
traveling providers.
Yeah. So that's part of the mix in the update and some pretty big numbers, but just FYI. Well, hey, thank you. I think we're done. I don't know how we're doing for time.
We're close. Right on the money.
Perfect.
Yeah.
Yeah.
All right.
Thank you. I'll do my part to encourage the other partners to show up.
Appreciate that, Scott.
Yeah, I'll try to do the same.
Great. Thank you both so much.
Yep.
Thank you.
Okay, thank you.
Take care.
Awesome. Thanks.
Thanks.
You.